as previously said in both of the presentation, that aspirin is there in cardiovascular prevention. Certainly, its role is a bit questionable in primary prevention, but it's there in cardiovascular disease. But we'll look on to that issue as well, that why is it questionable in primary prevention, and is it really worth for that evidence is worth for our population or not? Let's start with the disease process. We know that this coronary artery disease starts with endothelial dysfunction, lipid deposition, inflammation, and thrombosis. If you look on to the phases of cardiovascular disease, it starts as atherosclerosis, which is initiation and progression of atherosclerotic plaque. And this atherothrombosis leads to events. And whenever you have a patient with atherosclerosis, you really don't know whether your patient is having atherosclerosis or not, because that you judge on the basis of risk factors. And a day when he developed this thrombosis, he is labeled as a patient of cardiovascular disease. But how can it possible that aspirin give benefit to a patient who developed thrombosis and had atherosclerosis one day before and is giving no benefit at that stage, but will give benefit after that thrombosis? So it's a complex issue, need further evidence to clarify exactly the role of aspirin in primary prevention and in which patient, whether it's really on in very high risk or not. We'll see later in the moment. This is the stage, because we are saying this patient having no cardiovascular disease till this rupture of plaque. Is it so that he's having no cardiovascular disease at that stage? We are saying that this is primary prevention. It's not primary prevention. Aspirin is there for prevention of events, because the bed is with atherosclerosis. So it's very complex to understand what's going on with this disease. But certainly, you have to go wherever evidence is taking you. So till at present, the evidence is not favoring much of its use in low risk primary prevention. And this is the stage: endothelial damage, rupture plaque, sequence of platelet related events, adhesion, activation, aggregation, and triggering of clot mechanisms. And what we are giving aspirin or any antiplatelet is for this event, which is there after plaque rupture. Every role is there of a platelets, which is leading to this plaque progression and events as well. Here you have the role of your antiplatelets. And these antiplatelets affect every step of this thrombus formation, adhesion, activation, aggregation by their mediators. And this plaque rupture is the culprit for all the events. Before plaque rupture, even you don't know whether your patient is having disease or not. You judge it by means of risk factor control, risk factor assessment. And you have multiple antiplatelets available, which were used since last 20-30 years, along with aspirin, ticlopidine, clopidogrel, prasugrel, ticagrelor. Then for peripheral vascular disease, celestazole, even diparacetamol. For acute emergency threats, you may use glycoprotein 2B3A as well. But for chronic persistent use, especially in cardiovascular disease, still aspirin is there. Now we are adding on low dose anticoagulant as well for prevention of that events, and that is again for atherothrombosis. Regarding the mechanism of action, we all know that there are multiple pathways which you have to address, and that's the reason for using dual or triple antiplatelets, or even adding on anticoagulants to take care of that cascade of coagulation, which is the culprit after plaque rupture of bringing the events. But in spite of all those availability, addressing those multiple pathways for prevention of disease, still aspirin is being used as a long-term prevention, secondary prevention. Mechanism we all know, so I'm skipping that. I'll just quickly go through its uses. Although very much questionable in primary prevention, but still in very high risk patient, weighing the risk of event and bleeding, still it's used in very high risk. In secondary prevention, still it's there, starting from stable IHD, non-ST elevation MI, unstable angina, ST elevation MI, peri-PCI status, and in all of these conditions for a long-term use as well. And these are the evidence for secondary prevention. Clearly, their primary prevention evidences are questionable, especially with the recent 3-4 big studies. But still, in terms of secondary prevention's role is there, aspirin 75 to 162 if known CAD or non-ST ACS, aspirin following PCI or fibrinolytic therapy for ST elevation MI, and aspirin 85-75 daily following PCI for long-term use. Even you can use low dose of aspirin as well. Finally, in conclusion, considering the disease process itself, thus atherosclerosis is a process which starts very early in life, and that's the, even showing those figures, I was saying that when we say primary prevention, are we saying prevention of atherosclerotic disease or prevention of events? It's not prevention of atherosclerosis disease, because the disease starts there at very early ages, and that can only be assessed by the risk status of the patient. And certainly if your patient is having multiple risk factors, he may be harboring those plaques within the vasculature which can bring the events. So still, we especially in our setup, when we are not taking proper care of all major modifiable risk factors, we certainly need evidence for our population. Is really aspirin has no role in those multiple risk factor patients who are at very high risk of developing that atherothrombotic events, considering that they may have their bed of the arteries with those plaques. So we need evidence. But at present, the evidence are not suggesting their aspirin use in primary prevention, but I think there is an initiative by Professor Javed Akram in terms of answering this question to have that a large study in our population. And that, again repeating, atherothrombosis leads to major vascular events at any stage of atherosclerotic process. We don't know when this plaque is going to rupture and give you an event. In terms of that, a patient who's having no disease day before non-ST elevation MI, and that day he will be having in the category of secondary prevention. So aspirin is indicated for all patients with atherosclerotic disease, that is secondary prevention, who had shown evidences of disease in terms of events, and high risk primary prevention as well. Thank you for your patience listening.